Welcome everyone to our third event this year, COVID Vaccines and the Return to Life Part 3, the latest on variants and breakthrough infections. We are delighted to have four absolutely top-notch experts joining us today. I'm Kira Peikoff, and I'm the editor-in-chief of Leaps.org, a not-for-profit initiative that publishes award-winning journalism about innovation, ethics, and the future of humanity. Our mission is to restore public confidence in scientific innovation and to reckon with the ethical implications of new breakthroughs. Leaps.org is published by Good and Upworthy, and we're grateful for program support from Leaps by Bayer. And we're very delighted to partner with the Aspen Institute Science and Society program for today's event.
Thanks, Kira. My name is Aaron Mertz, and I am director of the Aspen Institute Science and Society program, part of the Institute's broader Health, Medicine, and Society program. Science and Society was established in 2019 with the mission to elevate public trust in science and to help foster a more diverse and more engaged scientific workforce. The program is grateful for general support from Johnson & Johnson, the Rita Allen Foundation, the Kroll Charitable Trust, and the Smart Family Foundation of New York. I'm also welcoming the audience on behalf of the Sabin-Aspen Vaccine Science and Policy Group, which brings together senior leaders across many disciplines to examine some of the most challenging vaccine-related issues and drive impactful change. This event is brought to you with generous support from the Gordon and Betty Moore Foundation and the Howard Hughes Medical Institute. The format of today's event, and if we can switch to the other slide, that'd be great. We'll be rotating conversations between two of our panelists at a time, as illustrated in this image. They will engage with a prompt question and then have a freely flowing discussion for about 10 minutes, at which point Kira or I will come on to say that our time is up. The first speaker will drop off and will be joined by the next speaker. The pairings will continue until speaker 4 converses with speaker 1. Then we will bring all the panelists back at the end for a Q&A fielded from the live chat, the Q&A feature at the bottom of the screen, and questions submitted in advance during registration. So throughout, please submit your questions in the ways that I mentioned.
So for our first paired conversation, Dr. Bhadelia will interview Dr. Iwasaki. Dr. Akiko Iwasaki is a professor of immunobiology and molecular, cellular, and developmental biology and professor of epidemiology at Yale School of Medicine, and she's an investigator at the Howard Hughes Medical Institute. Her lab researches how innate recognition of viral infections leads to generation of adaptive immunity, and how adaptive immunity mediates protection against subsequent viral challenge. Dr. Nahid Bhadelia is the founding director of the Boston University Center for Infectious Diseases Policy and Research and associate director of the National Emerging Infectious Diseases Laboratories at Boston University. She's an internationally recognized leader in highly communicable and emerging infectious diseases with clinical, field, academic, and policy experience in pandemic preparedness.
Thank you for that introduction. And it really is my pleasure to be talking to Akiko because I've been following her work throughout this pandemic, like all of us have, in terms of making sense of what's going on both within our bodies, but also how we take this emerging body of science and make sensible public health policies and individual decisions. So Dr. Iwasaki, Akiko, I wanted to ask you about something that there's a lot of confusion about. There was a recent CDC study last Friday that maybe provides some insight on this, which showed that vaccines tend to reduce the chances of infection by 5 times compared to those who are not vaccinated. But there's a lot of confusion about breakthrough infections and about how common they are. And based on your research, can you explain to our audience the role of antibodies and T cells in gaining immune protection through vaccination and what that means about the severity and likelihood of breakthrough infections?
Yeah, thank you so much, Nahid. And it's also my pleasure to be on this panel with other experts that I also admire, including you. So thank you. So first, let's just define for the audience what it means to say there's a breakthrough infection. So breakthrough infections are defined as detectable viral RNA or antigen in respiratory specimen collected from a person 14 days after they have completed all recommended doses of a vaccine. So vaccine breakthrough is expected because no vaccines are 100% protective against all infections. And also breakthrough infections can be either completely asymptomatic, mild, moderate, or severe. So before the Delta variant arose, there were much less breakthrough infections, and we didn't really hear too much about it. But after the Delta has kind of predominated over the globe now, we are seeing more increases in breakthrough infections. However, the vaccines are still quite effective in preventing severe disease and hospitalization and death from COVID-19. So really depending on the vaccines and the studies that you look at, they're hovering between 60 to 90% effective in preventing hospitalization following breakthrough. And it also depends on the age group you look at, as well as the vaccine types. And so we are seeing mostly older adults having a severe case of breakthrough infection when you look across the different studies. And so the asymptomatic and mild infections from breakthrough is the predominant case. And the current evidence indicates that people who are fully vaccinated, their likelihood of developing long COVID after breakthrough infection is also reduced by about less than half compared to the unvaccinated population. So I'll just go on to answer your second question about the immune responses that are induced and what's actually preventing infection in the disease. So in order to prevent infection altogether, you need local mucosal immunity. And even though current vaccines are not designed to elicit mucosal immunity, which is really the immune responses, antibodies and T cells within the nose and the oral cavity, you see some neutralizing antibodies that come across these tissues and provide pretty good protection against infection. With mRNA vaccines, we're seeing neutralizing antibodies in these cavities. So this may explain why infection can be prevented in many cases, even though it's an intramuscular vaccine. And even if infections were to take place, the vaccine-induced immunity, that's circulating antibodies and circulating T cells, can quickly detect and block further spread of the virus. And so this can contain the infection to the upper respiratory tract before it transmits to the other parts of the body, including the lower respiratory tract, where you can get pneumonia. So antibodies not only neutralize the virus, but can really prevent further spread as well as killing the infected cell through engaging innate immune system. And T cells, of course, they detect and eliminate infected cells. So vaccines are really good at inducing all types of patrol cells and effector molecules. And then at the same time, there are these memory cells that are also circulating, and they detect this virus and immediately respond. They divide and they become more robust to prepare for the future infections. So there's a lot of layers of immunity that the vaccine creates that protects us from, generally from severe diseases, unless you are either immunocompromised or are older adults with comorbidities.
Thank you for that, Akiko. I wanted to ask you two related questions, and I wanted to tease out also this term sterilizing immunity, which I think has caused a lot of confusion. I think when people hear that, there's been misinformation just around the term sterilizing. So I think it's good for us to sort of stress the fact that when we say sterilizing immunity, it refers to what you were talking about, which is enough of an immune response in the mucosa so that the infection doesn't take a foothold. The question that I had was comparisons, what we know so far about the immunity that comes from natural infections compared to immunity that comes after vaccination. And then also with this very robust T cell response, memory response that we have, what does that mean for the long term in terms of both efficacy against staving off infections after vaccines, but also potentially natural infections?
Right. So that's another issue that a lot of people are talking about now, with whether naturally acquired immunity is better than vaccine-induced immunity. And it really depends on how you define immunity and what's better versus what's worse. Obviously, none of us are advocating for people to get infected in order to acquire the immunity, because that can carry so much risk of disease and long-term symptoms. But if you were to have gotten infected, let's say, because you couldn't get access to the vaccine or prior to vaccination, that type of immunity does provide a quite robust mucosal immunity, as I mentioned, because you acquire these viruses through the mucosal surface, which then establishes tissue resident memory cells, which are sort of resident there so that they can provide quick immunity once you encounter the virus again. And so there's the sort of natural acquired immunity has the advantage of kind of creating this mucosal immunity that's a direct and immediate barrier to infection spreading. However, as I mentioned, curiously and very fortunately for all of us, the mRNA vaccines are inducing some of these mucosal immunity, even though it's given intramuscularly. And so we are benefiting from this impact of having some antibodies in these mucosal tissue to prevent infection and spread and disease.
Yeah, I'll mention from a public health perspective, there's very clear benefits to not getting an infection and rather getting the vaccine, which is why the struggle to try to get vaccines all over the world so that we don't, basically damn the rest of the world to go through an infection is so important. And those three reasons, main reasons in my mind to not get infected. One is, and you can probably stress on this more than I can, which is that there seems to be variability in terms of immune response after infection-induced immunity. And so with asymptomatic or milder cases potentially not having the same strength of immune response with neutralizing antibodies. Second, being the fact that when you get an infection, you are risking potentially getting critically ill, and hospitalization, it's like a car crash for your body. Recovery from that, from a severe illness carries long-term issues. And not only that, but we also know and are trying to understand, and I know this is work that's important to you as well, long COVID, the idea of what happens if you get an infection itself. In my mind, the last reason why it's probably important is public health reasons. If you're infected versus getting the vaccine, you are more likely to pass on that infection to other people as well.
Yes, I'd like to stress on those points that you made, Nahid, because I get a lot of questions from people who are asking me, well, I had the COVID before, what's the point of getting the vaccine? And we actually measured antibody titers and neutralizing antibodies in people who recovered from infection versus those who got the vaccine after the recovery from infection. And there's a huge difference in the titer as well as functionality of these antibodies against not only the ancestral strain, but all the variants. So there's a benefit of getting the vaccine, even if you've had COVID, and you probably had COVID a while ago, which means that you could really use a booster using the vaccine. So I totally agree.
Yeah, and one other thing that occurs to me is that there's a lot of conversation, and I know we're probably running out of time. We could talk about this all day. Is this idea that immune response that results from vaccines are very specific, right? They are aimed towards the spike protein, and our immune system in its messy glory, the way that it creates antibodies, it's the scatter shot. It then starts to perfect itself, a bit more. And so you might have a more diverse set of antibodies versus to a more specific immune response, from what I understand. And you might correct me on this with vaccination as well.
That's right. Yeah, there's some differences in the breadth and the strength of the response, depending on what vaccines you get or whether you had prior exposure. But the vaccine kind of normalizes all these differences by giving everyone about the same, or if not better, immune response if you've had COVID before. So I think that there's very little downside to getting vaccinated, even if you had COVID.
Great. And I will pass on the baton to you.
Okay, great.
Thank you so much for that conversation. Now, Dr. Iwasaki will interview Dr. Pepper. Dr. Marion Pepper is an associate professor and interim chair in the Department of Immunology at the University of Washington. Her lab studies how cells of the adaptive immune system called CD4 positive T cells and B cells form immunological memory by visualizing their differentiation, retention, and function.
Hi, Marian. It's great to have you here. And I'm going to ask you the first question. So there's the CDC's messaging about the viral loads in the vaccinated versus unvaccinated people led to a lot of confusion over the summer. Can you help us clarify how likely are vaccinated people to get infected by Delta in the first place and compared to the unvaccinated?
Well, it's really nice to see you, Akiko. And yes, I'd be happy to talk about that. I think it's really important to go back to those studies that the CDC released and to really focus on the fact that those studies showed what we call CT values, which is they basically looked for remnants of virus. They didn't look for whether there is a productive virus that can actually transmit from one person to another. And I think that was a really important distinction that a lot of people have made. But the question of whether Delta can actually be transmitted from a vaccinated person is a really important one as well. And I think, as you just said very clearly, it's really impressive how well these vaccines are working. But they have this very strong goal of reducing disease and death and hospitalization. But having an infection is pretty commonplace, even in vaccinated people. It's rarer than in unvaccinated people. Here in King County in Seattle, you have a 7 times higher rate of getting infected if you've been unvaccinated than vaccinated. But if you start to look at what the levels of getting symptomatic disease and hospitalization, you end up having a much, much greater chance of having disease or being hospitalized if you are unvaccinated. I think you just really nicely introduced how the immune system works, but it's important to remember that there are these neutralizing antibodies and antibodies that function to activate the innate immune system that can control the virus, but those do decline over time, and that's a normal part of the process. But underlying those vaccines, we have all of these cells, these multiple layers of cells that you brought up, that are really capable of getting reactivated and controlling that virus really rapidly. And that therefore prevents that dissemination of the virus into the lung and that building up of disease and clinical symptoms, which is why people aren't getting sick. So it is definitely possible to get infected, especially by the Delta variant, if you've been vaccinated. That chance is lower if you have been vaccinated than if you are unvaccinated. But more importantly, these vaccines are really doing their jobs well at preventing disease and preventing hospitalization. So even if there is one of these breakthrough infections, the rest of your immune system will kick in sometimes within even hours to kill the virus and prevent illness.
Yeah, that's a very clear message. Thank you, Marian. So just kind of following up on that, how about the likelihood of vaccinated people spreading an infection?
Yeah, and this is another tricky question because it's hard to measure exactly how much virus a person has in their respiratory tracts, and people are starting to look at this. But the early studies that have emerged have shown that people clear virus more quickly if they've been vaccinated than those who are unvaccinated. And there are a few studies that are coming out now that are also showing that if you can isolate virus from people who've been vaccinated, that virus is less able to infect cells in culture than those from unvaccinated individuals. So it does appear that vaccines are creating these immune mechanisms in the nasal passages where the virus is being encountered that is not only preventing dissemination and actively killing the virus, but potentially preventing that spread as well due to reduced viral load.
Great. And so are the chances of transmission significantly lower if you're asymptomatic versus symptomatic?
Yeah, I would hypothesize that they are, since symptomatic infection is associated with that virus really disseminating into the lungs and really causing that pathology that we've all heard about that ends up with low oxygen levels and all of those other symptoms that lead to hospitalization. But I don't know if those studies are out at this point. But my assumption is that yes, if you are asymptomatic, it means most likely that your body has cleared that viral infection before it's become really problematic, and therefore, you will probably transmit less virus. But I think those studies are yet to be seen.
So Marianne, you were one of the first persons to really study sort of memory response, in particular the T-cell memory with respect to naturally acquired immunity. And there are much fewer studies that look at T-cell immunity than antibodies. But what do you think about the T-cell immunities that are induced by vaccine versus natural infection? And what does it mean for us going forward?
Yeah, thanks. That's a good question. So yeah, our lab started studying how the immune memory cells form, both the T cells and B cells, in response to natural infection back in March of 2020. And we've actually been following those individuals over time, comparing them to individuals who have just been vaccinated, who haven't actually had COVID-19, and also comparing those to individuals who were first infected and then vaccinated. And we do see very reassuringly that the immune response of a person who's had a natural infection, when they get vaccinated, gets boosted dramatically, as we would expect, meaning that even though there may be fewer of those cells over time, they're still rapidly responsive. They're able to function well. But we also see similar types of patterns in people who've been vaccinated, and we see a very strong T-cell response in people who've been vaccinated. We see slight differences in the actual function of the T cells. We can actually detect some different molecules that are either expressed on the surface of those cells if you've had a natural infection versus a vaccination, and the types of molecules that those cells are able to release to reactivate other cells nearby. And we're still looking into this, but what we see overall, and I think most importantly, is that whether you've had natural infection and been vaccinated, or whether you've had 2 vaccine doses, you're inducing very strong T-cell responses that we think are very functional at activating the entire immune response and inducing control of the virus.
Well, that's very encouraging to hear. Yeah. Thank you. And so in terms of, all these studies that are coming out and trying to find a correlate of protection with different vaccines, why do you think the T-cell aspect has been not ignored, but very difficult to come by?
Yeah, I think there are a couple of things that are influencing that. First, I think antibodies are easier to study than T cells. I mean, you can just take a blood sample and pretty rapidly measure how many antibodies are specific for the virus in the blood. Whereas with T cells, these are very rare cells, these memory T cells. Basically, the way the immune system works is you keep a few hundred to a few thousand of these cells constantly patrolling through your circulation. Now, there may be these depots of these cells in the tissue sites, but we can't really measure those very easily. So we're kind of limited to studying those rare T cells that are circulating throughout the blood. And it takes some pretty specialized techniques and tools to pull those T cells out and be able to study them. So I think it's harder to study the T cells than the antibodies. But I think there are more and more studies that are showing these correlates of protection, that you need these CD4 T cells to reactivate the memory B cells, which are also antibody secreting cells that are capable of boosting that antibody response. And so I think it's really important that we get a good understanding of how those cells persist and function. And we've been spending a lot of time tracking those cells and trying to reveal that.
Wonderful. I really enjoyed those answers. Thank you very much. I'll
Yeah.
pass the baton over to Kira.
All right, thank you both for that excellent discussion. And now Dr. Pepper will interview Dr. Adalja. Dr. Amish Adalja is a senior scholar at the Johns Hopkins Center for Health Security, an adjunct assistant professor at the Johns Hopkins Bloomberg School of Public Health, and an affiliate of the Johns Hopkins Center for Global Health. His work is focused on emerging infectious disease, pandemic preparedness, and biosecurity.
Hi, Dr. Adalja, Amish. Nice to meet you. I was curious about your thoughts. You are obviously very focused on public health and thinking about what we need to do to get through the rest of this pandemic. And I think one of the things that's come up a lot recently, and I think a lot of us have been thinking about and grappling with, is this need for a booster shot. And do those individuals who have already been vaccinated need a booster shot to lessen the chance of breakthrough infections? And what are your thoughts about the pros and cons of a booster shot, a third booster shot?
So this is a difficult discussion. And I think it comes back to what we've just heard in the prior discussions of what do we want a vaccine to do? And I think throughout this COVID-19 pandemic, we've wanted our vaccines to prevent serious illness, hospitalization, and death. And by that measure, they're performing off the scales. And to me, that's the threshold for needing a booster, because the fact that we get mild breakthrough infections that don't require medical attention, that's expected because vaccines aren't bug zappers, they're not force fields, they're not meant to be able to stop every infection. And I think that we've gotten, people just don't quite understand that concept. And I think you have to couple that with the fact that COVID-19 is not going anywhere. It's going to be established in the human population. We're going to have COVID cases 10 years from now. And I think we've got to take a step back and say, did our vaccines are they doing well? Are they holding up? And to me, they are, because if you walk through a hospital, and I work clinically about 50% of my time, who's being hospitalized are not vaccinated individuals. They're unvaccinated individuals. And that to me is what we have to continue to emphasize. And when you look at the third dose that was added for immunosuppressed populations, that was actually based on clinical data. They said those people who were immunosuppressed were overrepresented in the hospitalizations, people with solid organ transplants, for example. But none of that data has been presented for the healthy population. And there may be a day that we need vaccines and boosters, but I don't think it's necessary at this point. And I think the whole process kind of went reverse, where this was announced by the White House before we've seen any data. And I think it's not surprising that our community, the infectious disease community, has pushed back hard because it doesn't necessarily make sense.
Yeah, I think there are two really important points in there. The first is, what is the end game, right? What are we trying to accomplish by a booster vaccine? And would we ever be able to reduce transmission to a degree that will get rid of this disease? And I think, as you just said, I think the better way to think about this is to really think about endemicity and getting comfortable with this idea of SARS-CoV-2 becoming an endemic virus that we all are going to have to deal with.
Yeah, that's something I started saying very early on. I wrote like this blog post in January, I think of 2020, saying the 5th seasonal coronavirus, because you've got 4 others, and people kind of laughed at me. But I think that was something that wasn't accepted by the general public or even by our policymakers. And it's kind of guided the way that we've done everything, because we took a very abstinence only approach to everything rather than harm reduction, which is what we do with other infectious diseases. And now people are having a hard time realizing that this COVID, in the sense of the fact that there's always going to be some baseline number of cases and hospitalizations, that's the foreseeable future. And I think it's really stunted our ability to move forward. And it's also kind of undersold the vaccines, because our vaccines are meant to make this more like those other respiratory viruses, like those other 4 coronaviruses, and that's what they're doing. But it's so hard now to distinguish between breakthrough infections and breakthrough disease and what deserves a public health response and what doesn't. But if our goal now is to stop fully vaccinated people from getting the equivalent of common colds for most of them, there's no off-ramp to the public health interventions that are going on. And I think we've got to be clear about this. And putting third doses into people that are highly vaccinated doesn't change what's happening in Mississippi or Kentucky or Texas or wherever it might be. First and second doses are what matter. Third doses don't matter that much.
And what, just to follow up with that, what are some of the other things that people can be doing to prevent transmission beyond getting a booster, if the booster isn't really going to accomplish what we're talking about doing? Obviously, getting unvaccinated people vaccinated, but what are other recommendations as an infectious disease expert that you have?
a lot of this is going to fall to your individual risk tolerance, because now we're in this stage where people are out there doing things. And what we got to do is give people the ability to make better choices. So if you're somebody if that's really risk averse, or you are worried about getting a breakthrough infection, you can continue to wear a mask. You continue to try to be around people that are fully vaccinated or have natural immunity, so that you're not around non-immune people. If there's activities that you need to do that are social and you're worried about it, do them outside, open a window. There's a lot of harm reduction steps that you can take to make this less of a disruptive event to your life. And we've gotten finally rapid tests. So rapid tests are also a way to minimize the risk that somebody that you're around is contagious. So we've got a whole host of things that we can do to minimize the disruption COVID-19 is. But I think that a booster isn't, I think there's probably no harm in doing it, but I don't know that there's a benefit or that it's necessary, or if we're going to be in this situation where we're continuing trying to boost people that are already highly immune while there's all these non-immune people in the country and in the world, and we still have a major disruptive event going on because the pandemic is not controlled.
And so you would still say, though, that the exception to that is obviously immune compromised, which you already said, but what about people over the age of 75?
So there is starting to be some emerging data that maybe there will be subgroups of the general population that need boosters, maybe nursing home residents. But again, we want to see clinical data, not just, so you just mentioned earlier about antibodies. Everybody looks at antibodies and lab tests, but they're totally missing like the other whole arm of the immune system, which are the T cells, which are hard to measure. So people just decide not to talk about them. But that's really what I think is important. So if we see data that nursing home residents, people above the age of 75 are getting breakthroughs that are severe, then I think you have an argument for a booster in that population. But someone like me, I'm 45, I was vaccinated in December 18th and January 8th for my 2 doses of the Pfizer vaccine. I don't feel like I'm in bad shape right now. I don't think that I need a booster vaccination, but there may be subgroups. But again, it has to be driven not just by lab data, not just by antibody data, but by clinical data, the way they did for the immunosuppressed population 3rd dose.
Yeah, that's a great answer. And one of the other things that you said is this level of endemicity that we're going to have to get comfortable with. And I think one of the things that is now being discussed quite frequently is what is the level of death and hospitalization, and how do we approach this so that we aren't constantly shutting down, we aren't revising mask policies, things like that. Where do we go there?
I think you have to maybe use influenza as a baseline. And I think in the United States, we probably have, anywhere between, 3 to 36,000 deaths or something is what the CDC estimate is. That's sort of what endemicity looks like for a similar respiratory virus. And I think, to me, what all the public health interventions had to be geared upon was, are our hospitals in trouble? Are they unable to keep pace with cases? And that should be, to me, the trigger for when you think about mask recommendations or testing recommendations, or that goes above and beyond what people are doing normally. And a lot of that has to do with the fact that if you have your high risk population immune through vaccination or through natural immunity, then you kind of decouple cases from hospitalizations and from deaths. And I think for many parts of the country where they do have high levels of vaccination, or in certain countries, they already have seen that decoupling. We didn't see it in all of our states, but I think in the Northeast, most of the hospitals, even though there's an uptick in hospitalizations, they're manageable because of the vaccination of the high-risk individuals. So I think we've got to go back to, if our hospitals are okay, and I think we have to do well to help the hospitals and make sure they can expand capacity, then I think that there's probably not as much of a role for public health intervention. There's definitely going to be a role for personal responsibility and private businesses to say that they want to do this. But for the government, I think it has to be keyed on hospital capacity being compromised.
That's super helpful. Thank you. All right, well, I will let you now take over and pass the torch.
Thank you so much. We're going to bring Dr. Bhadelia back.
Hi there.
And we have a leadoff question for her.
Hi, Nahid. It's great to meet you virtually. I've been following you throughout the pandemic, and I think the work you did with Ebola and emerging pathogens and setting up the whole biocontainment unit, that's really important work that I think is going to pay dividends to the whole country in the future. So I wanted to ask a little bit about this idea of long COVID, because it's something people talk about a lot. As I've been focused on severe disease, hospitalization, death, but long COVID is something important. And one of the questions that keeps coming up is, if you get a breakthrough infection, yes, you're not going to need to see a doctor for the most part, but is there a chance that you might get long COVID, or how do you think about counseling people on long COVID risks who are fully vaccinated?
Yeah, I mean, and same here. Like, watching the work that you've done with global health security has been so important in helping set up the infrastructure and thinking about how we make the world safer against emerging infectious diseases. But let me start there, because I think, what we've learned from emerging infectious diseases is that you have to be humble. You learn about their full spectrum of manifestations as you're taking care of patients. And long COVID certainly, for me, kind of echoes back to the Ebola experience. We've taken care of like hundreds of Ebola patients, and then recognizing, even if they were lucky enough to survive, they may have this post-Ebola virus disease syndrome. And here we are again with COVID-19, with this question of, a percentage of people who survive the acute infection who may go on to have persistent symptoms and potentially new symptoms, and new studies are now showing likelihood of development of new medical conditions. The trouble is that we don't have a good enough handle of what long COVID is. There's been some attempt to give a definition by WHO, by multiple public agencies in UK as well as here in the US, and it's really defined as persistence over a certain amount of time after you've had the infection of symptoms. And what we understand, and I think the reason this question is so important, is it goes back to your discussion about endemicity. Because if we talk about, if this is endemic, the answer of how big a burden is long COVID, what is long COVID, what is that risk, to an individual becomes important, because that then becomes one of the things that individuals consider as part of their risk, profile, and whether or not they're going to take activities. The short answer is we don't know. The NIH has invested over $1 billion and set up cohorts, which are just starting to recruit. We have a cohort at my hospital that I'm leading on long COVID as well, and we're just gathering information on what might cause this. We understand there are a couple of factors to what causes long COVID, and it really goes to answering the question that you asked about breakthrough infections on long COVID and the studies that have sort of looked at that. What we know is that there's a portion of people who, when they're acutely ill, when they're severely ill, the impact of that severe illness itself can have an impact on recovery. And for a long period of time, as you know, as a clinician, there's been literature on post-intensive care syndrome, the idea of going through an ICU and how long that affects, your mental status, your, dementia, PTSD, medical conditions. But there's also evidence, of the damage that this virus does. And for the sake of those who are not scientists on this conversation, just talking about what this virus does in the acute setting, right? It infects your cells, it causes damage to your organs directly, but then it also affects your blood vessels. They're everywhere where there are, the ACE receptors that we've been talking about, that the virus uses to enter the human body, the human cells. They exist in so many different organs, and you can see that this is a multi-system infection or multi-system disease in the acute setting. Beyond that, the virus seems to cause, blood clots. It seems to cause this very maladaptive, hyperinflammatory immune response. And the long COVID part of this is, what is long COVID? Is it an extension of what's happening in the acute setting? And then you continue, is it something else that we don't yet know? And some of the things that I think Akiko's looked at, and we've had a small study on this, is potentially autoimmunity, the idea that maybe you develop an immune response that's not helpful and is actually harmful. There are studies that looked at the fact that, there are people who are more severely ill tend to have more autoimmune antibodies. There's others that have looked at the fact that people who are severely ill tend to have autoimmune antibodies against parts of the immune system. And so it makes their immune response not as effective. We had a small study that looked at survivors 9 months out and showed that they had greater number of autoimmune antibodies compared to pre-pandemic, subjects. And that's a very small study. It needs to be borne out. It doesn't tell you anything. It tells you that you need to sort of follow and see what's happening in these patients over a longer period of time, because autoimmune antibodies are seen in many viral infections after recovery. And so you really have to be able to attach it to people who have long COVID to show that. There are other things that I won't go into, but this idea of, I'll present anecdotal evidence first, and then I will talk about the studies for a second. Can you get long COVID after you've had a vaccine and then you have a breakthrough infection? Yeah, we're actually seeing people in our post-COVID clinics. We're seeing patients who've gotten vaccines who recover, who then get the vaccine, unfortunately have the bad luck of getting infected, and then may have persistent symptoms. And studies have shown, there's an Israeli study of healthcare workers. I showed about 20% of healthcare workers who were vaccinated who had the infection ended up having persistent symptoms. But the real question is, what is that compared to people who might have had an infection and didn't have the vaccine? And I don't know that we have yet solved that. There's hints to that. There's a study, there's this app-based study, survey study that was published in Lancet. You know, I'm always hesitant about these because it's people who answer surveys or maybe part of an app who are interested in long COVID may be different than the general population. And in that, there is an evidence that shows that in people who were vaccinated, got their 2 doses, got a breakthrough infection, the incidence and persistence of symptoms was half compared to those who were not vaccinated. But I think that needs to be borne out with more study. In my mind, it's clear if you get vaccinated, the chances of getting long COVID are lower because vaccination reduces your chance of getting the infection in the first place by 5 times from what we know from the CDC. So I'll stop there, but you know, it's a really interesting and evolving topic of scientific inquiry.
I think going back to what one of the things you said was about a definition and trying to narrow that down. And to me, I try to say, you know, you have to make long COVID distinct from post-ICU syndrome, which are critically ill people, which we know are not going to get back on their feet. And then you kind of have to delineate the symptoms, which ones actually limit your activities of daily living and which ones don't. And because if you look at some of those studies, they say maybe a person has a chronic cough, which we know can happen even after influenza for 6 weeks, or there's abnormalities in taste and smell, which might be important for certain professions, but not for all. And I think that's part of it, is trying to narrow down what percentage actually have activity of daily life limiting. And I think that's one of the big mysteries, or one of the big tasks for science to actually do, is be able to winnow this down, because then we can actually, I think, treat it or understand it a little better.
Yeah, and Akiko has actually presented this in the past, anecdotal evidence of this, but also I've heard this from many patients. For long COVID patients, the inverse is actually also true. Those who get vaccinated, their symptoms seem to get better in some cases. I've seen that from patients who've reported that to me, you know, and when I've spoken to them about this. But as you said, I think that we are a long way from answering that. I think the establishment of cohorts, right? I think that you need, part of the problem with prior studies is that the controls have not been appropriate, you know, and again, the methodology of all the studies that have actually reported this, as you've rightly pointed out, have been all over the place. They've all used different definitions. And so there's NIH cohorts that are being set up now nationally, to be able to follow, you know, a set of people and have a preset definition to be able to identify that, and then to do deep, both phenotypic analysis of like, what are these symptoms, but also virological analysis as well as immunological analysis is going to shed some light on that.
And I also, you know, we talk about this kind of long tail of symptoms with other infectious diseases. You mentioned Ebola. We probably would have that with influenza if we actually studied it in great detail. Clearly, we have an issue with Lyme disease and these post-treatment Lyme disease syndrome and that whole controversy, the Epstein-Barr virus. And I wonder, you know, if this is very similar to that, or how you would compare and contrast them, because to me, it seems to be very similar in terms of the symptoms and in terms of kind of the mystery. When you look at, because I've had patients with long COVID and their blood work is all completely normal, just like I've had patients with, you know, post-treatment Lyme disease or with mononucleosis and then never really get back on their feet. And I wonder if there's a common pathway there that might be eventually discovered.
Yeah, there's it's so interesting. And, you know, as you know, from emerging infectious diseases research, you always find what you're looking for, you know, or let me put this another way. You can only discover when you look for things. And so the absence of, you know, the absence of evidence is not evidence of absence. And in some ways, you know, as you say, because COVID-19 is one of the most studied infectious diseases at this point, because of the amount of resources that we've put, it does bring about sheds more light on potential dynamics that are also underpinning other similar disease interventions. And even Epstein-Barr virus is a perfect example of that. You've seen long-term like literature on EBV and increase in autoimmune antibodies, and there's never been this like ability to link that to the persistence of symptoms that people have after that. There's a lot of conversation about the chronic fatigue syndrome and, you know, the ME sort of, you know, the disease entities and whether there's a linkage between those. I do hope that what we find from COVID, or at least tease out in terms of pathophysiology, but also how we improve symptoms for people who have this is going to help people with other disease entities as well. So far, I can tell people who are sort of interested in long COVID, the way physicians, clinicians like Dr. Adalja and myself are sort of in many of the long COVID clinics, huge part of it is addressing the symptoms that people have, whether it's through physical therapy, through cognition, through if it's PTSD or something along those lines that's more mental health support is those, but then also if it's pulmonary recovery or things like that, it's really been symptom based in terms of how long COVID clinics have approached care for patients who have severe persistent symptoms.
I think have you seen any treatments actually have major benefits? I know, for example, there were some people that talked about that postural orthostatic tachycardia syndrome, POTS, and people getting, because of some vasculopathy or vascular infection that occurs with COVID. And some of those people have gotten better, at least it seems. And you also mentioned some people have anecdotally gotten better after being vaccinated. So I wonder what treatments you guys are thinking about in your clinic.
Yeah, again, aside from, as I mentioned, huge part of this has been more symptom, based and relief of symptoms. Short of the vaccination itself and short of, of medications that help relieve symptoms, we at least have not engaged in anything that might actually be targeted medical therapy against the virus itself or the impact of what might be going on. Because to do that, I think definitively, we probably need a little bit more of a signal of what it is and what's causing it.
I think that we're at time, so I think now we're back to the public Q&A.
Thank you. We're going to ask all of the panelists to turn their videos back on, and we are going to bring in questions from the Q&A and also some that were submitted in advance. Kira has the first one.
So while this is a conversation focused on breakthrough infections, we have been getting a lot of questions about kids. And so I'm wondering if we can just take a moment for the panel to address the timing and challenges around the vaccines in the 5 to 11-year-old group, and also how dangerous is the Delta variant to this age group.
I guess I can take a first stab and then people can jump in. So I think in general, it remains true that children are spared the severe consequences of COVID-19. They're not necessarily going to be hospitalized or die from this, but they can get infected with it. They can spread it. And one of the things with the Delta variant, it's important to remember, is the Delta variant is looking for unvaccinated people. And if you're under the age of 12, you're not going to be vaccinated. And our vaccination rates in the United States for those between the ages of 12 and 17 is low. So kids are going to get infected because Delta variant is out there. And because they're spared from severe consequences of disease, they're mostly out there doing their activities, going to summer camps, going to sports, hanging out in their friends' basements, playing video games. So they're going to get infected. And I think when it comes to the vaccine, it's important that we do this right, that there's a proper risk-benefit calculation. Children are not young adults, or not little adults. There is a group, especially when you're talking about that younger age group, 5 to 11, where they're really spared from severe consequences, that there's a lot of concern to make sure that we get this right, that the risk-benefit ratio favors the vaccination there, that the dosing is right. And I think people are frustrated about it, but I think we want to make sure that people have confidence. We're dealing with a really virulent anti-vaccine movement, and I think they are ready to pounce on this vaccination for children. So if there is any misstep or anything that looks like it's rushed or not the right way, you're going to see lots of people get the children vaccinated, but we're going to hit that wall again. And I think that's another important factor to keep in mind.
Yeah, just adding to it, Amish, that, with kids, I think part of what FDA did with vaccine manufacturers was actually ask them to increase their recruitment numbers, which is why there was a greater, time to finishing the trials as well. And part of it was because with the potentially less likelihood of severe disease in children compared to adults, the onus is on, really showing that there is an efficacy, as well as making sure there's no rare safety signal. And for the reasons that Amish talked about, it's important to ensure that we get this right. Having said that, the advantage is very clear, and I think that we tend to say, people who've said, oh, this is not such a big threat to children. I think you have to look at the fact that children were in a really different place last year compared to this year. They were not going out as much. The society at the very beginning had sort of closed down. And yes, some schools started, but this is a more transmissible variant, and so even if it was not the individual child and that child's health, which clearly is a consideration, the fact that children do transmit disease and they make a big percentage of the population and are a road to us achieving, some level of sort of equilibrium with the amount of immunity in our society. They childhood vaccination plays a big role in that. So just in terms of timeline, Pfizer submitted data, says they're going to submit data in the next few weeks in terms of the trial itself. They have the primary data, and then the FDA would look at that and go through the process of potentially getting an EUA after that.
Okay, I'll ask the next question. To what extent do you feel immune escape from variants from vaccine-acquired immunity or infection-acquired immunity is plausible, and on what time scale? How likely is this? Are there lessons from other viruses about this possibility?
So I'll jump in, and Marian, maybe you can follow. So essentially, we've been looking at immune escape variants, mostly in vitro, but also looking at real world data. And even though Delta, as I mentioned, after the Delta variant has emerged, there is more breakthrough infections. It's not because Delta is able to escape the immune recognition. It's mostly because it's very highly infectious and transmissible. And so the variants like the Beta and Gamma, which are more immune escape capable, are not the dominant ones. And they've been sort of outperformed by the Delta variant because of its transmissibility. And so right now, I don't think we have a huge concern about immune escape variants, at least at this point, taking over the other variants. The Delta variant is highly transmissible, and it's very capable of, kind of even making breakthrough infections. But in most cases, as Marianne described, those infections are more quickly contained within the vaccinated.
And I just wanted to add to that, I think for a lot of the studies that have looked at immune escape, they've taken either individual monoclonal antibodies, or they've taken serum from people who've been infected or vaccinated and looked just to see whether those antibodies can actually neutralize the virus. But again, it's really important to remember that T cells are really hard to evade. T cells can recognize very short sequences of a protein, and you can change one or two of them, and the T cells can still recognize those sequences. So it's important to remember that we haven't really looked at all immune evasion across all types of cells. Most of these studies have been done looking at antibodies, and the memory B cells as well, which don't necessarily constantly make antibodies, but can get reactivated to make antibodies upon a secondary infection, are also very diverse. So I think from the immune system perspective, the immune system has also evolved to be able to recognize these closely related structures beyond just the antibodies that so many people have been measuring.
Thank you. And another question on boosters. So even though we haven't gotten a formal recommendation from our government about this, we are already starting to see a number of people go out and get third shots and just say that that's their first shots. And these are oftentimes healthy people who aren't necessarily concerned about hospitalization, but they just don't want to get sick at all. How much can a third shot for an immunocompetent person actually increase their protection? And are there any known harms in just going out and getting a third shot?
I'll take a little bit of a stab at this first. The thing is, there's probably no harm in getting a third dose, but we don't. That's actually what we've been asking for. Is there clinical data to support the use of a vaccine as a third dose to prevent you from getting a breakthrough infection, even if it's mild? None of that has been presented. What's been presented is antibody data, and that's not enough because, again, what Marian just said, T cells are really, really important. So I think we still go back to this issue, is that this has to be a clinically driven data. This has to be driven by clinical data. Whether that's preventing severe disease or even preventing mild breakthroughs, they actually have to present data to show that a third dose actually does that, and they haven't. And I think that's what we all need to see before we make this decision. And hopefully the ACIP does ask for this data or has that data if they're going to make a general recommendation.
One question that I have for Akiko and Marian is, one of the for those who've talked about the third dose have said, part of the reason we may need a third dose is we spaced the first two doses too close together. And we partly did that because we were in a rush to get an answer to see if these vaccines work. And the data from the AstraZeneca, trials has sort of shown spacing out the doses may have greater efficacy impact. So from that perspective, and not so much, not so much whether we eventually need that many doses, but do we need a booster simply because it would be a more appropriate boost for the immune system compared to what we did? I wonder what you think about that. I'm actually with Amish on this. I think that there's clear data for immunocompromised. I think there's clear data for people who are older, and public health imperative to do that. But for everybody else, maybe it's the fact that so little of the rest of the world is vaccinated. It seems to me like overkill. Like you can't create a fortress of humoral immunity in one country only and imagine that's going to protect us, particularly, when there are so many others who are potentially going to suffer the consequences.
Marion, do you want to go first?
Oh, you go ahead, Akiko.
Okay, yeah. So yeah, I've been kind of an advocate for spacing out the booster dose because actually based on Marion's work when she was a graduate student, she really, looked at the kinetics of memory T cell formation, and it really does require a certain amount of time. So if you space it out 2 weeks, 3 weeks, 3 weeks is probably the earliest you can sort of capture these memory cells and re-stimulate them properly. But 3, 4 weeks and 6 weeks, 12 weeks, these are the kind of spacing that people have studied already. And clearly spacing does tend to have an increase in antibody response, but it didn't really have much of an impact on the T cell immunity side of things. So I'm not sure if the spacing is really the answer to the booster, whether a particular vaccine is more effective versus another. But I also want to just insert one issue, which is that we've been kind of focusing on the mRNA vaccines, but there are J&J vaccine. It's a single shot, and it does have more breakthrough cases, and it does also have more severe breakthrough cases. So when we're thinking about booster dose, maybe those are the people that need the booster dose first, and then the mRNA vaccinated people, maybe the healthy population in general could wait a little bit longer.
Yeah, I totally agree with that, Akiko. And I would also add that there is this really fascinating thing that B cells do over time where they actually change what they're specific for, and they're able to actually modify what they're able to bind in this specialized environment called the Germinal Center. And those Germinal Centers can last after infection. There was one study that showed that they're lasting after immunization for 15 weeks. And the product of those Germinal Centers are these diversified B cells that can recognize more varied types of closely related pathogens. So I think that spacing is a really interesting question. I don't think we know all the answers about that yet, but I do think that the breadth of the response could possibly be altered by that spacing if that booster has an impact on how long that Germinal Center persists.
Thank you. On the note of boosters, one of our viewers asked for comments about applying booster shots versus investment in vaccine distribution among countries with lower vaccine coverage.
I'll take a stab at that. Less than 3% of low-income countries have been vaccinated. And when you leave entire segments of the world completely unvaccinated, you are leaving them vulnerable to continued outbreaks that debilitate their healthcare systems. I'm not even going to talk about, the benefits to us. Yes, we all know the reduction, the first doses are better. They help us or reduce transmission. They will help reduce chances of new variants appearing. Yes, all those things. When you leave entire societies in debilitated outbreak sets, their healthcare systems can't take care of other medical conditions. Their healthcare workers get overwhelmed. They potentially, lose the capacity to be able to monitor multiple other infectious diseases. We've seen, reduction in tuberculosis diagnosis, HIV treatment. We've seen, the idea that if your healthcare system and your surveillance systems are already overwhelmed having to deal with COVID, you may miss other emerging infectious diseases. It's not even to go to say that, the impact that we've seen economically here in this country. I think it's like the numbers are 95 million more people being pushed into extreme poverty. There's, famines, food insecurity. You're seeing fallback on childhood immunizations, because the other vaccines are not being delivered in places because of the outbreaks. You're seeing, fallback on not just childhood education, but also women's empowerment and the ability, because women have to stay home because they work in informal domestic sectors. And, if your economic sector is not working, that has an impact. All of that to say that it adds up to a more insecure world, which comes back to us, because a world that's not able to recover from this pandemic, both dangerous from perspective of not being able to look out for other diseases, but also potentially social instability that may lead to conflict and other issues.
Okay, thank you. And another question we have, is it better to wait to get a booster if it's recommended for your population when there's a variant specific one, or are the original ones sufficient?
I can take that one on. So far, the evidence seems to point to even the original strain booster being really good at, and by booster, I meant sort of the second shot, and then in the Moderna and Pfizer studies that came out more recently about boosters. It seems to be able to diversify the response quite similarly to what we would expect if you had actually changed to a different variant. So the data so far seem to suggest that I think a booster with even the original strain and the original protein in that strain is good at diversifying that response and boosting that response in a way that it will be protective.
Thank you. Could any of you comment on data on recurrent infections? We hear about breakthrough infections and infections in unvaccinated individuals, but there are examples of people getting COVID more than once. What have you learned about those data that you've seen so far?
I'll give a little bit of my thoughts on that, and then hopefully other people have more to say. I think that there's still reinfections occur, at least in the short term. They appear to be rare, and we know from other coronaviruses, remember the 4 other that caused the common cold-like illness, the reinfection is pretty uniform after about a year or so. But those are usually mild infections, and I think that's sort of been borne out by what we've seen here. But the point is that natural immunity, though it's not nothing, can always be increased by getting a vaccine. And I think that's the message. And I think that this is something I think we should try to think about incorporating into guidance. That, like in Israel, for example, if you've got prior infection, you need 1 dose to be fully vaccinated. And I know that there's a lot of vaccine hesitant people out there that think that natural immunity is being ignored. So I think that this is something that needs to be addressed. And I think we need to kind of acknowledge that it is not nothing, and it might actually be significant in many instances. For example, with the Delta variant, there's evidence that it might even be better than vaccine-induced immunity, but I defer to the immunologists on here.
I might argue against that last point. There is a study that I think that you're probably referring to that showed that there was better immunity if you'd had natural infection versus vaccine-induced immunity. And I think the only thing I would say is that there was survivor bias in that population. Everybody that they were looking at that had natural infection had made it to that point. So I think we have to be really careful about comparing those two.
Yeah, just to kind of follow up on Marianne, I agree with what she said exactly. And also there's another UK study that looked at naturally acquired versus vaccine-induced immunity. And they sort of like were pretty comparable. It's between the mRNA vaccine and the adenovirus vector vaccine. So, and again, as you said, Amish, I think having a booster will even increase that protection even further. So yeah, I think the conversation has to be informed and also incorporate multiple different studies.
Thank you. Another question on people's minds. Can you mix different boosters from different companies, Pfizer, Moderna, and J&J?
I'll talk about the public health policy, and the immunologist can handle the science part of that. The current CDC recommendations are if you can, you should just get the same manufacturer, so not different technologies. Let me clarify. There's a question of, can you do two different technologies, which some countries have done. France, for example, has done the adenovirus vector with an mRNA vector as a series. And it's interesting, I've not seen any cohort data on that. There haven't been trials, clearly, but I should point out the reason sometimes you don't see these kinds of trials is because they're from two different manufacturers. And a lot of times, two manufacturers may not want to study their products together. And so I'd be really interested to see what we find from some of the data from France and other places that have used the two technologies together. Then there is the two manufacturers of the same technology, and CDC recommends that you should try to stick with the same manufacturer. So if you did Pfizer, you should stick with Pfizer. But if you can't, then it's okay so for example, if you got Moderna doing Pfizer or vice versa. But right now, that's the recommendation on the public health side.
Yeah, I think from the immunology standpoint, there are studies that have done like small clinical trials looking at antibody levels and neutralizing titers, and mixing the adenoviral vectored vaccine followed by mRNA appears to be better at boosting antibody response than adeno followed by adeno. But the mRNA followed by mRNA is just as good. So I think, whatever vaccine recommended for you within your own location, it's probably what you should do. And I would adhere to the public health guidance on this.
Thank you. Here's one specifically for Dr. Pepper. You mentioned that virus taken from vaccinated patients was less effective in lab studies at infecting cells. Can you talk about the mechanism underlying that and what that teaches us about these vaccinations?
Yeah, that's a great question. I'm not sure we know exactly what the mechanism is yet. Are those viruses, coated with antibodies? Have they been exposed to some sort of immune molecules that have rendered them sort of less potent? We don't really know that information yet. But I think those are important studies to find out, because I think they'll really reveal mechanisms of immune protection that are important.
Okay, thank you. We have another question. What do you expect annual vaccinations for COVID as is done with influenza, in part to adjust for new variants?
I'll start and then let the immunologist take over. I don't think that we can actually extrapolate flu to COVID-19. They're totally different viruses, totally different viral families. And I think that what we see with flu is that it's always drifting away from the vaccine, and in a way that we worry about protection against serious illness, hospitalization, and death if we don't update the flu vaccine. So there is I think the COVID has drifted away somewhat from the vaccines, but I don't think to the degree that you see with influenza. And I also think there's data that shows that maybe at least there's some people are speculating that a third dose is probably, maybe this should be a 3-dose regimen and then you're done, because the vaccine-induced immunity is so strong. So I just kind of caution people against making comparisons to flu, because even though they have similar symptoms, it's a totally different viral family, totally different genetics, and totally different way of evading the vaccine. But again, defer to the immunologists.
Yeah, I absolutely agree with that. It's a completely different viral sort of lifestyle and strategy. And so, yeah, I don't think it's going to be an annual vaccination strategy for the coronavirus, but we just need to see what happens. I mean, before the variants started emerging, I thought that the 2 shots and mRNA vaccine were done. But because of the infectious nature of the Delta, and in the future, we might encounter immune evasive variants, which we currently don't have a very effective immune evasive variant. If that were to occur, we may need to adjust the vaccine to match that particular evasive variant. But so far, we don't see that. So yeah, that's my take on this.
Thank you. Could you comment on the delivery of these vaccinations given intramuscularly, or if there would have been any merit or future merit to giving them subcutaneously or other delivery approaches?
I'm going to defer to Akiko on this one, because she is an expert at thinking about where these different vaccines should go and how to get the right immune response.
Thank you, Marian. Yeah, so I'll try. As I mentioned, even the intramuscular vaccines right now have some crossover to the mucosal surface in providing neutralizing antibodies, and that's providing protection against infection. However, next generation vaccines that target the mucosal tissue, that provide tissue resident memory cells in that tissue, as well as transporting this IgA, secretory IgA, which is really great. They're kind of much more stable and much higher avidity against viral surface proteins. If we can generate a vaccine that does that, then it can really stop the transmission altogether. So that would be great. But right now, we should be very happy with what we have. I mean, the current vaccines are pretty amazing still. So, but if we're very, very picky and thinking about future vaccines, mucosal vaccine might do just that.
Thank you. And we're getting close to the end of our time, so we'll try to fit in a couple last questions. One is, can breakthrough infections in vaccinated people lead to new variants that can evade the immune system? And if so, would this be a reason for pushing a booster?
I'll start again and then defer to the immunologists here, but I don't think that it's very common to see a breakthrough infection be something that's going to allow the virus to replicate enough to get all those mutations. I think that there's always been some talk about, would vaccinated people or partially vaccinated people generate variants? And I don't think there's any data to show that that's the case. I think what you're seeing in these breakthrough infections is, as what Marian said, very defective viruses that aren't very fit. So I suspect that you're not going to see new variants emerge that way. But again, I'll defer to the immunologists.
100% agree.
Me too.
Thank you. Could you explain to our audience what we mean by vaccine efficacy? We're throwing around a lot of percentages. This one's 90%, then it's reduced to 50% or 66%. What do these numbers actually mean?
I mean, I can jump in. I think there are different ways to talk about vaccine efficacy. I think there are some studies that are focusing on positivity of infection. There are others that are focusing on symptomatic disease. There are others that are focusing on hospitalization. So, but I think generally, I think you have to be specific about which type of vaccine efficacy you're talking about. But yeah, I think I'll leave it there.
And I would just add that when you look at those numbers, it's not like if something has 90% efficacy, that if there was 100 people, 10 people got infected, it means you're 90% less likely. So it's even better than that. So I think that's something that the general public and even the press got wrong when they were talking about 90%, not realizing that's a risk reduction. So it's a lot of biostats there that are sometimes difficult for the general public to understand.
Yeah, I was going to also add to that. I think that we tend to confuse efficacy and effectiveness as well. Efficacy is something that you see in trials, and effectiveness is the total whole number of how the vaccine performs once it goes through all the real world challenges that you might encounter after it's been released. So all the cohort studies that you're seeing, those are vaccine effectiveness numbers rather than vaccine efficacy numbers, which is what we saw in trials.
Great. Thank you so much. We are out of time. I want to thank our 4 outstanding experts for sharing their experience and knowledge with all of us. We have recorded this session and we will have it on YouTube later today, so you can share it with your colleagues and family and friends.
And please stay up to date with us at leaps.org and the Aspen Institute Science and Society program. We will be bringing you one last event this year on a topic to be determined as things evolve with COVID and our vaccines. So thank you again, everybody, for attending, and to our wonderful speakers.